The first thing I think of when I think of COVID is devastation.
COVID for me was just totally heartbreaking, very sad.
I think about all the sacrifices that the staff in this unit have made.
Telling visitors no, they can't come in has been the hardest part of COVID.
I think of trauma, I think of separation from loved ones, and I'm happy that we're kind of closing that gap now.
I am truly proud and honored of these heroes that I work beside.
Hello, everyone, and welcome to our presentation titled Nursing from the Frontlines, Nurses and the COVID-19 Pandemic. I am Julie Sherman. I'm the Associate Chief Nursing Officer here at Tufts Medical Center, and it is my pleasure to present to you the anatomy of a pandemic through the eyes of the nurse. Today, we will walk you through a timeline of events as they unfolded this past 16 months. You will hear stories from Tufts Medical Center nurses and how they are leading in their profession. We will share with you stories of how nurses on the front lines innovated to change their practice to deliver safe patient care. We will discuss resilience, strength, and support, and how do we all move on and still be able to care for patients with the kindness and compassion all in this new era. We will offer up a time at the end of the presentation as well for Q&A. But I invite you during the presentation to please utilize the Q&A feature at the bottom of the screen to enter your questions. And I will do my best to thread them throughout the presentation as well as get to them at the end. We also had quite a few of you submit questions ahead of time that we've kind of embedded into the presentation, and we hope we can get to all of them as we can. I would like to now introduce our panel of exceptional nurses. Please meet Suzanne Menninger and Sarah Roth. Suzanne and Sarah are infection preventionists who are our source of information, our strengths. We're always there to help with our nurses, to help guide with the most updated evidence-based practice guidelines and keep us informed and keep us safe. Next, I would like to introduce to you Antonia, or otherwise known as Tony Maloney. Tony is a cancer nurse specialist that works in our adult ambulatory cancer center. Next, I would like to introduce to you Emma Powers. Emma Powers is a nurse who works on our complex med-surg floor that ended up flipping to be a COVID-19 floor caring for COVID patients. And lastly, I would like to introduce to you Elizabeth, or otherwise known as Lulu Foy. Elizabeth, or Lulu, is a nurse that works in our medical intensive care unit that ended up flipping it as well and became a COVID-19 unit caring for patients. And with that, I would like to invite Suzanne to begin our presentation. Here's our timeline. Introductions. Okay, Suzanne, take it away.
Hi, everybody. For this presentation, I wanted to reflect on the major events of this pandemic and speak to you about what was happening, what we knew, how we were feeling at each milestone. So let's begin with the anatomy of a pandemic. So back in December 31st, 2019, there was a viral pneumonia in Wuhan, China that was reported to the World Health Organization China office. The source of this was believed to be a wet market, and there was no human-to-human transmission, and it was named the novel coronavirus. And you might have seen it depicted as 2019-nCoV. Almost a month later, by January 21st, 2020, the World Health Organization issued its first situation report. There were now 278 confirmed cases of this new coronavirus. 51 were severely ill, 12 were in critical condition, and there were 6 deaths. There were already cases in other countries that had links to Wuhan, such as Thailand, Japan, and Korea. And even in the United States, there was a case in Washington State that was linked to travel to Wuhan. By January 21st, we did know that human transmission was confirmed, and the disease was actually not named COVID-19 until about February 11th, 2020. So this is our COVID timeline at Tufts Medical Center. So on January 8th, we received a HAN alert from the CDC, and HAN stands for Health Alert Network. The CDC issues these on a regular basis, and you can read this one in its entirety on their website at emergency.cdc.gov. This alert mentioned a pneumonia of unknown cause reported from Wuhan, China, again, possibly related to a live fish animal market. It does mention that there is no sign of human-to-human transmission or healthcare workers getting sick. The CDC designated travel to Wuhan at that time as a level 1 warning, which means practice the usual travel precautions. And very often these HAN alerts, especially in relation to zoonotic or animal transmitted infections, do not amount to anything serious. The last paragraph, however, caught my eye as it mentioned that if caring for a traveler from Wuhan who has pneumonia, healthcare workers should wear an N95 respirator. And I imagine at this time, many of you had not heard of an N95 back then, but it lent a seriousness to this HAN alert that prompted me to consult our hospital epidemiologist, Dr. Shera about posting a travel warning on our internal website. It is our practice to maintain a posted list of countries with outbreaks of infectious diseases that a traveler could contract. I'll share our very first COVID email correspondence on the next slide. Dr. Derone is always mindful of the risk of a respiratory virus pandemic, thought we should be cautious and agreed that we should add this to our travel screening reference and also test our travel screening process to be sure that it was working. Personally, I was relieved that the travel warning was limited to China because I had planned a long-awaited trip to Puerto Rico for the end of the month.
You know, Suzanne, just a quick thing. There's a question that came through the Q&A ahead of time, and I'd like to tie it in and ask Sarah to comment just for a second. I was hoping, Sarah, can you comment, especially since Suzanne was not planning to be here. What was it like during that initial week when we got this, this notification, et cetera? And if you could also add to that question, what is it to be an infection preventionist? There's a lot of questions that came through that. What is that? How do you prepare for this type of role, et cetera?
Yeah, so I mean, definitely the first couple notifications we got, we did kind of brush off. I mean, we do this every day in infection prevention. We get notifications, we get little tidbits of information, and we have to decide whether they're worth acting on or not. We train for this. We've been training for this pandemic, you know, as long as we can remember. We work very closely with emergency management. I know Suzanne has gone to a lot of different trainings. I've gone to several different FEMA trainings on emergency preparedness, pandemics. We drill in the hospital. You know, annually we look at a risk assessment, and we look at our hospital's unique location and type of patients we serve, and we look at the threats that we perceive, and we'll drill on those as needed. So, you know, being an infection preventionist, I have to explain this a lot. I think people say, well, you're a nurse, but what's infection prevention? What do you really do? And the easiest explanation I think that I've come up with is we keep people in the hospital safe. And that includes both the employees as well as the patients. So, you know, we do that in a variety of ways, and we have a lot of different modalities we employ, but definitely preparing for pandemics and emergencies are high on our list.
Wow, I can imagine this was tough to prepare for. What was it like during that first week when this alert came through and Dr. Derone recommended that maybe we should post something to our website?
It definitely got stressful quickly. We were really looking at information. What information could we gather? What was out there? What was the best evidence-based practices we could put into practice in the hospital at that point to keep staff safe? And this is about the time we began looking at the PPE or personal protective equipment that we were going to need should we begin to see these patients in our facility. And we began to consider, you know, sort of pre-contemplation, what kind of training that would take of the current staff.
Nice.
All right, so as the world began to realize the potential dangers of this new coronavirus, our local health authorities, in combination with CDC, developed a case definition. And a case definition helps clinicians know what kind of symptoms and exposures to look for. It also defines who should be tested for the illness. This early case definition focused only on travel to Wuhan, and testing for the virus was limited to this narrow definition. And if you remember also in the beginning, tests had to be sent to the CDC in Atlanta, so we could not test anyone who did not meet the case definition. At that time, we also had to run flu tests, and if the flu was positive, the COVID test could not be sent. And on the next slide, I'm going to discuss how the case definition evolved. So again, it was travel focused at the beginning. And we learn in infection prevention training that Sarah mentioned that in an emerging infectious disease, the case definition can change many times as we discover more about who is getting ill, how the virus affects the body, what are the symptoms and the outcomes. And it can seem like misinformation is being given from professionals, but honestly, we expect to learn during these pandemics, and we often have to make recommendations based on only what we know for certain at the time, which can be limited. So this slide shows the abbreviated summary of how the 2019 coronavirus case definition evolved. So it was initially travel focused, then it expanded to include critically ill patients who basically didn't have a reason for their pneumonia. So if you ruled out flu and other types of pneumonia, then COVID tests could be appropriate. At this time, the state was given test kits, but the supply was still limited. So the criteria for testing remained limited to only those who met the current case definition. As community spread became prevalent, anyone with fever, cough, or shortness of breath became suspected cases. And eventually the case definition evolved to the one we have today, which includes a host of symptoms as well as asymptomatic people. Testing became more accessible when hospitals were able to purchase their own machines and test kits, and Tufts Medical Center did so as soon as they were available.
Now, a quick question. I believe at this time we would still consider business as usual, right? So just a quick question. I'd like to direct to Tony, if you don't mind. Just reflecting on the community and the ambulatory practice, like, did you see an uptick in patient calls at this time? And how did you respond to that? Like, what was the mood like when patients were calling? I can imagine there was a little bit of panic or et cetera, but the fear of the unknown.
Sure. So I'd say looking back that the general feeling at that time was a state of panic for sure. Patients were calling with questions about, can I still get my treatment? Can I get my COVID test? I have symptoms. I'm not sure if I need a COVID test. So what we did as oncology nurses is we really kind of had to take a step back, and we had to listen, and we had to absorb a lot of those fears and anxieties that the patients were feeling. Because as Suzanne said, at the time, there was really limited resources for testing. So everybody calling in asking, can I get a COVID test? Well, we really had to, prioritize that and make sure that we were using our resources sparingly. So yeah, a lot of anxiety, and I think the nurses in general did a great job kind of, diffusing that anxiety and listening to patients.
Yeah, thank you. Thank you.
So by January 27th, concern about travel from China or contact with travelers began to worry the community. Our clinics that cared for neighborhood patients began to get overwhelmed with phone calls about people wanting to get tested because of travel or close contacts with travelers from China. But testing at this time was still limited, but this was our first inkling of how parts of the healthcare system can become overwhelmed. We quickly had to reinforce ambulatory services, and the first case in Massachusetts was actually February 1st, 2020, which was a few days later. On January 27th, also, we began our personal protective equipment refresh program. Our infection prevention team directed the PPE refresher training with help from nursing, emergency management, and environmental health and safety. Over 1,000 people were retrained initially, including fittings for those N95 masks, of which the brand would change several times, which we'll talk about the challenges that created because of supply chain and changing guidance.
Sarah, real quick, what was it like then? Like trying to get 1,000 people trained and and trying to calm everybody's anxiety and fears all at the same time?
Yeah, Julie, it was a definite challenge. And as Suzanne mentioned, she was on vacation, and that's when these things happen, right? You know, they never happen when you've got your full staff there. They happen either in the middle of the night or when someone's on a planned vacation. So that brought our 3-person team down to 2. So we got help from emergency management, environmental health and safety. A number of other folks jumped in because we had a large number of employees that we needed to train on the prescribed PPE at that point in time. Yes, and a lot of questions, a lot of concerns. A lot of concerns with folks at home. You know, I have a immunocompromised child. I care for my elderly mother. Things like that that we were trying to address as fast as we could and give support that way.
Nice, thank you.
And this is beautiful Puerto Rico. It really was difficult being there knowing what was taking place back home. And on the next slide, I would like to share a little bit more about our PPE situation, because there have been a lot of news stories about PPE shortages, especially during the first COVID-19 surge. So it was around February 7th, 2020, that there was concern about the supply chain for hospitals. And there were many factors for this. Some of our supplies actually came from China. There were outbreaks at production centers. There were shortages of raw materials and sometimes just excessive demand. Many times we thought a shipment was coming only to find out it was delayed or only partially fulfilled. So to help with this, what I'm showing on the slide is that CDC published a 3-phase guide for PPE conservation, especially face masks. Phase 1, called conventional, is the routine way we use PPE, which in many cases is to just use it once and then dispose of it, and that's the safest way. Phase 2 was called contingency, and that encouraged us to practice extended use. This meant that we could keep a mask or some eye protection on throughout the day and go from patient to patient. Now, we spent a lot of time writing many protocols to describe situations where we felt extended use would be safe for our staff. The last mode is called crisis mode, and this was basically designed for a time when PPE becomes extremely scarce, and it is the highest risk mode because staff would potentially be removing contaminated PPE, storing it, and then putting it back on. We all worked hard to avoid crisis phase, which sometimes meant tweaking protocols many times. These would then have to be disseminated to all staff, and the infrastructure would have to be put in place to support these protocols. We also had to be cognizant of the information overload on the staff, and we worked with a nursing communication liaison as well as our PPE support team to control this. We did collect N95 to be reused, but we never did have to put them back in circulation.
So this brings up a quick question about practice, right? So one of our audience members posted a question about how did your practice change with the guidelines? And Tony, I was hoping that you could speak to all the work that was done in the cancer ambulatory clinic for innovation to ensure safe patient care, as well as deliver cancer care to patients, because that could not be delayed, I imagine. Could you speak to that a little bit?
Sure. So we knew from the get-go that we did not want to delay patients' treatments. It wasn't an option for us. So we immediately put a plan in action to make sure that our patients could safely get into the medical center in the midst of a pandemic and receive their treatment. So the first thing that we did is we developed a COVID task force team. And in that team, we had members of nursing, physicians, we had our chief of medicine, admin, so multidisciplinary. And we basically met 2 to 3 times a week.
Well, I think we've got some technical difficulties. Someone froze. Are you there? Is everyone else still not frozen?
I'm still here.
Okay, good. All right. You know what? I'm sorry that happened because there was some great work that was done in ambulatory cancer where we had they had to quickly flip their clinic and split it into two, where they cared for patients receiving cancer and symptomatic patients. A lot of innovation done with nursing, with working to keep patients safe. So that was wonderful. Next slide.
Sure, I can add. I spoke to the clinic a lot. They were always thinking ahead about different scenarios that their patients might encounter, and they consulted us a lot about different ways to make that happen so that patients could continue to go to that clinic. All right, so now we go to, mask guidance changed over time for the public, but also for us. The CDC provided guidance that an N95 mask was preferred, but that a regular face mask was safe and acceptable also. So my team had to devise protocols based on the theories of infection transmission as to when an N95 absolutely had to be used. We also performed a lot of article and protocol review on medical grade masks because some of the masks that were entering the hospital supply chains may not have been of the highest quality. There was so much demand for masks. One of the issues that kept me up at night personally was scouring CDC, OSHA, and FDA websites, making sure that our staff was well protected by the PPE that we had for their own safety and also so they could continue to care for patients.
Yeah. Just a quick question, because N95, not N95, use it, not use it, safe, not safe. Sarah, how did you keep nurses, support staff, physicians, etc., educated as to what the best mask to use is and to actually ensure safety?
Yeah, that's a great question. And because a lot of our recommendations would change from day to day, the way we typically look at the hospital as infection preventionists is we divide the responsibilities up. Certain infection preventionists have certain areas of the hospital. So, as these concerns arose, we would try as best we could to stick with the covering infection preventionist or IP. So for instance, if the pediatric area had a concern, they were worried about something, I would see if Suzanne was available because that was her area that she was covering at the time. We also had some change in responsibilities. Around March, I went to nights. So I think that did really benefit us as we had 24-hour coverage with an infection preventionist. We brought folks in from other disciplines that, like our operating room for a period of time shut down. A lot of the clinics did shut down and people were working remotely. So as many of those clinical folks as we could have come in and assist us with that, we did. We, like Suzanne said, we were just constantly looking for the most up-to-date information so that we could educate staff and feel confident what we were telling them. And Suzanne has a good point there. What kept her up at night? It was similar for me. Am I telling them the most up-to-date information? Am I keeping them up to date? Am I keeping them safe? That was really the biggest thing for me was making sure that staff were being kept safe with the information that we were giving to them at the time. So yeah, we did a lot of work to support staff and try to educate staff because there was a lot of misinformation floating around as well.
Yeah. Thank you. Just I want to give Emma a quick question because, given all this information and Sarah, and you have all the team giving you some support, how was it for you knowing that you're going in to care for patients, and how were you feeling? Did you have the right mask? Did you not have the right mask? Did you feel safe? Like, what was going through your head?
Yeah, so I mean, it was definitely scary to start out, obviously, but we always had this new information coming in, like you said, new masks, but we always felt like we were supported and that we always had the proper equipment. I know on my floor, right outside the rooms for any COVID patients, we had a cart fully stocked with gowns, gloves, goggles, masks. And then inside the room, we would have a table set up with any sort of equipment that we needed to safely get out of the room, to wipe any equipment down. And we always had somebody, a support staff or another nurse or a clinical care tech outside of the room to help us to make sure that we were coming out of the rooms safely. So we always felt supported, even with all the new information we were giving on a day-to-day basis.
Yeah, thank you. Imagine that was a little terrifying there.
So, our supply chain team kept finding sources to purchase N95 masks or the equivalent, but each time we changed brands, the staff had to undergo what is called fit testing, and this is a picture of it here. And this was to make sure they knew what size of mask and what type of mask worked for them. Our safety officer, Gina Hale, was instrumental in making sure our staff could get fit tested when they needed to, but the different types of masks did make it challenging to stock care areas, and I think it was hard on the staff to keep changing masks.
Lulu, can I ask you a quick question? With all this information and stuff, how did you feel going in and caring for patients, like with all your PPE on? Were you afraid if there was a break in the PPE or you didn't have the correct mask on, you were going to be exposed unnecessarily? Or?
Yeah, of course. I think we all had that fear at first, especially when we started using the PAPRs and they were just so unfamiliar to us. But the people who came in and trained us on how to use them, how to correctly take them off, put them on, wipe them down, all of that were phenomenal. And they really did help ease our anxieties around it. There was still obviously some chance if it got disconnected for whatever reason, but we were just really careful because in order to take care of these patients, we needed to protect ourselves. And that was the main focus.
Oh yeah, that's great. Thank you.
Okay, so by March 18th, we had been preparing for the inevitable for over 6 weeks, but it was devastating nonetheless when our first staff members began testing positive from community exposures. The state was prioritizing healthcare workers' test results to help hospitals manage staffing, as workers with any cold symptoms basically had to remain out of work until they tested negative. When somebody was positive, we performed contact tracing. And I will never forget speaking to those first groups of staff who are identified as contacts and how real and devastating it was for them. In these huddles, I would review the science of how viruses spread and talk about symptoms to watch for and remind us the confidence that we had in the protection provided by PPE from our experience with other transmissible diseases. And we already had a robust hand hygiene program. A nurse from employee health would also speak to the staff about how they would provide support. And at this time, some of our colleagues at Tufts Medical Center also produced coping materials. I watched the video Dealing with Fear and Anxiety several times to help me understand how emotions could influence your behavior and your ability to learn. And I found the Grief in Healthcare During COVID video was also exceptional. You can find those videos on the Tufts Medical Center YouTube channel. These helped me personally and also helped me to support our staff.
Yeah, I agree. They're wonderful resources for everybody. Sarah, a quick question. Can you explain how the contact tracing was done, especially, with employees, with coming to work? Can you come to work? Can you not come to work?
Yeah, so contact tracing is something, again, we do that in non-pandemic times, and it's a daily function of infection prevention. We work very closely with employee health. So kind of what this looks like is anytime we have a patient with an infectious disease or an employee that might not have known they had an infectious disease that could potentially have exposed others at the hospital, we have to take a look at each of these cases individually. The first things we do is we come up with an exposure definition. So just because you were positive and I passed you in the hallway doesn't necessarily mean I was exposed. It can be fear-inducing. Especially in COVID, that's what we dealt with, is a lot of anxiety. Even though the science was there, we have a pretty good understanding of how this is transmitted. There was still a lot of anxiety that was going on. Even when people were told, you actually weren't exposed, and they still felt like they were exposed. And a lot of times they still sought out our employee health department. We have an excellent employee health department. They were very supportive of staff, even staff that just needed someone to talk to. I have a friend that tested positive. We were together. I'm nervous. I think maybe I was exposed. They were there for those employees and helped them through and got them in for testing when that was indicated. But yeah, the contact tracing was a lot of work, and it's a lot of resources for each one. You can imagine you have to go through this person's day and their schedule and look at everywhere they were, who they were around, and we kind of split it up. Employee health deals with the employees that are considered exposed, and infection prevention then looks at patients that they may have exposed that meet that definition.
I agree. I think, you even consoled me a couple of times. So I guess we could add counselor to the end of your credentials for both of you guys for sure. Okay.
So a day or two after the staff results, we had confirmation that many of our suspected patients were positive as well. Nurses were an integral part of the teams caring for these patients, and they needed to find creative ways to support the patient's loved ones as well. Some of them who are also sick with COVID are suddenly on quarantine and, separated from their families at such a critical time. The cases of COVID-19 rose exponentially, and some floors became designated COVID units. Medical floors transformed into ICUs, pediatric units cared for adult patients, operating room and clinic nurses became PPE support. Basically, day-to-day life in and out of the hospital was changing dramatically for us as nurses.
So Suzanne, you bring up a great point. Here we go, right? Emma and Lulu, you come to work one day, you're a med-surg unit, you come back the next day, you're a COVID unit. I'd like Emma to quickly comment on what that was like. Like, what was that like the next day you come in and you find out that now your unit is flipped and you're going to be caring for exclusively COVID-19 patients?
Sure. I mean, it was definitely a shell shock. It was, this is reality and this is actually happening. And it was scary to think about, when I go to work and I take care of these patients, am I bringing this home to my family? And I was never worried about me getting it. It was always a fair, am I bringing this home with me? And, trying to make sure that you take the same great care that we always offer to our patients, because we were the only source of support for them. So it was scary. It was a shell shock. Yeah.
Yeah, you just do what you do best though, right, Emma?
Exactly.
Great. And Lulu, if you could comment just briefly, because correct me if I'm wrong, but you were a brand new nurse, right? So you had just graduated from nursing school, entering your career, and boom, here you are. You're in an ICU that is now caring for critically ill COVID patients day in and day out. How was that for you?
Yeah, you are right. It was really scary. I luckily had the advantage of I was a tech in the unit prior to this, so I did have a little bit of exposure, but it still was terrifying because at times you would be the only person in the room for maybe a couple of hours. So you really had to have sharp critical thinking. And not only that, but you want to provide the best care to your patients. So just taking the time to really not only support them, but their families, and utilize all of the innovative things that we did with the iPads and the baby monitors and all that, really helped with the anxiety. Because I think that even though you felt like you were quote unquote stranded in your room that time, you knew that you could just yell out, and that someone by the baby monitors, who we would typically have someone by the baby monitors to make sure that they could listen out for people, would be able to come to your room in a flash to help out.
That's great. That's good. You have a good support system for sure.
Oh, absolutely. Yeah.
That's great. Okay.
So here is the graphic depiction of the COVID-19 surges in Massachusetts. The first surge peaked rapidly and ebbed a little bit slower. The summer was by no means business as usual, but the intenseness of the spring had lessened. A second surge was thought to be inevitable, so we were thinking ahead about preparations. We continued PPE conservation strategies. We had instructed staff to wear eye goggles and face masks at all time with patient interactions and with each other, as we learned about asymptomatic transmission of the virus. And it was very important to keep communications flowing and accurate. So there were regular hospital and nursing-based town halls featuring our internal experts. Let's see, the next slide. The second surge came in November, possibly fueled by holiday gatherings, and other states were having outbreaks as well. And this time we were definitely more prepared in terms of knowledge about COVID-19, its course of illness, its treatments, and the nursing care required. But this surge was longer and higher in numbers. By this time, just about everyone knew someone personally who had COVID-19, and there were lots of questions about exposures in the community and the risks associated with certain activities.
I would like to take a pause right here, because we are there's a lot of questions that came through the pre-question and answers and a few now. Recognizing that the second surge was bigger than the first, right? Emma and Lulu, I'm going to call on you guys right now because this is where it really hit hard, right? So a couple of questions that came through. Emma, can you go first? Like, how did you every day come to work knowing that there was sadness, that you needed to be strong, and you needed to be strong for the patients and their families?
Yeah, thinking back, I just did it. But you had to think of the patient that was in the bed, that you were their source of comfort, you were their support person. It was a terrible feeling having a patient tell you they can't breathe, they're having trouble breathing, and there was nothing you could do. You try your best to do the medication and the oxygen supplementation, but inevitably I would send them over to Lulu to, help them and hopefully come back to us on the other end of it. So I don't necessarily know how, but I think it was just our mentality is that we just do. And we provided phenomenal care to all of these patients. And I think, just being able to be their main support system when they couldn't have family members come in was amazing to see.
I agree. The care is phenomenal. And Lulu, how about you? Like a couple of questions coming through the Q&A about your family and going home to your family and trying to, stay strong for them and come to work and stay strong. How did you deal with that?
So I actually didn't see my family for quite some time because my roommate moved out and I was living by myself, which was kind of a bummer to be alone for, a few months at a time, but it was good being able to come in and socialize at work, because that was my one blessing, was being able to come in and talk to my coworkers. In regard to being able to come in to work, I kind of very similar to Emma, I just did it. Looking back, I think I subconsciously knew that our patients in a normal hospital setting are vulnerable, and they're at their most vulnerable points in time, and you're there to advocate for them, to comfort them, to help them. And now they don't have their family, so they're at an even more vulnerable point. And so just knowing that, and knowing that you can really create connections with them and their families, and that they're relying on you, was a big motivator for me.
Wow, Lulu, you bring up such a great point that you actually came to work for your support. Like, that's crazy when you think about the rest of the world needed to stay home and not go out into this very challenging environment. And yet you found comfort among your nurses and your support staff and colleagues. So that speaks volumes to that. Earlier, you had mentioned, Lulu, you brought up baby monitors and iPads.
Yeah.
And I know a lot of the audience has heard on the news about what that was, but can you just explain to some of us that, what you actually did to keep patients connected to their families, et cetera?
Yeah, so we have iPads. We have a few of them on our unit now. And what we would do is put them in a plastic bag to keep them safe and not as contaminated. And we would bring them into the rooms, or sometimes we can also position them outside the room so that the iPads are facing the patient. But even if they're intubated and sedated, we would have the families talk to their patients, because just hearing familiar voices, hearing "I love you," "we want you to come home," etc. So that not only can it help the patient, but it helps the families to feel like they are closer to them than what they were. A huge person that helped everyone in this hospital, I'm pretty sure, was Allie, our chaplain, who would communicate with the families, create posters with pictures, with things that the family would want us to tell their patient or their family members, our patients, every single day. Music that they liked, the families would create YouTube playlists of songs, of their voice recordings, so that we could play them at all hours of the day. And I think that was amazing for both the families and the patients, and also for us too, because we don't really know these patients, and if they can't talk to us, it's really hard to establish a connection. And so that way we can put paint a better picture of their true life outside of the hospital.
Yeah, very nice stories of just connecting with the patients and families when they couldn't. So thank you, very nice for sharing that. Lastly, just about this surge, the first surge and the second surge. So Sarah, I know you spent a lot of time in our command center, and you had spoken when we were talking a lot about the community support and things that were coming through from our colleagues outside of the hospital. Can you speak to some of that? Because I think that's really important to highlight.
Yeah, so anytime we have an emergency in the hospital, anything we deem an emergency, so it doesn't have to be the COVID-19 pandemic. It could be, a busted water main or something that's causing issues. We'll set up what's called the hospital incident command system, and that includes a command center, and it's kind of the brain of what's going on around the emergency operations at that time. So now, typically when I've trained around a command center before, it may be running for a few days, but then it's disbanded. Our command center was up for months because every day there was literally a new emergency that we were working through, that was a subset of the pandemic. So one of the things that we had down there is we had a lot of donations coming in. I was really touched by the community. There would be stories on the news about we were using baby monitors, or we were using binoculars, we were using iPads, and community members were bringing these items in, trying to support us. I had a neighbor down the street that he does woodworking projects, and he had a couple N95s, and he said, take these into work, you need them more than I do. I know Chinatown, they brought in a lot of donations. We're located in Chinatown, you're helping us, we want to help you. Food vendors were bringing us food almost daily, there were just free meals. So the support and the outpouring by the community was just so touching, I think, during this time.
That's great, thank you. And then Suzanne, just quickly speaking to the second surge, given that it was greater and longer than the first, how did you feel during the second one coming? And did you feel more prepared during the second one than you did in the first one?
Yeah, I definitely felt more prepared. I mean, things changed, and we actually maintained a web page that started out with just our protocols, but ended up having like all the hospital protocols on it. And in the second surge, the protocols didn't change as much, but we had some good treatments, but there were some sad events, and rounding, I would see the nurses taking care of these patients, doing whatever it took, right? If it was an intense medical condition state, they would be doing all the technology and using all their knowledge. And if things were not going to turn around, I saw nurses comforting patients. And it was amazing to me how you could just go from room to room and see different situations and how everybody just adapted. And it was really amazing. And especially the second surge went on for so long, I saw it a lot.
Yeah, thank you. Okay. Next slide.
Then we fast forward to December 15th, 2020, when we had our first employee vaccinations. So the FDA did authorize emergency use authorization for the Pfizer and Moderna vaccines at this time. And nurses were among the first to receive the vaccines and also the first to administer them.
So this is a really great slide because this is our first vaccine. The nurse giving it is Gina, and Dr. Gabriella is receiving it. Suzanne and Sarah, what are your hopes for the vaccine? And I have a question for you, and I'm sure others watching. Did you have hesitancy receiving your vaccine?
I can say with all my training, and I was so excited for the vaccine, and we were doing some presentations before it even was authorized. And, I was supposed to be later on the list, but that first week, the appointment, people weren't filling the appointments as fast enough, and the vials, expired after a certain time. So I got a call that they needed to use a vial to come now. And I did hesitate for a second, being like, well, I'm not ready. But, I went and got it. And I'm so thrilled that we even have this technology, to think that we can induce antibodies to a virus that no one's really seen before is incredible. And my hopes for the vaccine, I hope this allows us to go back to a normal life. We'll talk about a little bit that on the last slide, but to save people's lives. And if people do get COVID, that it's a mild case, and, there's no critical care patients and people aren't dying from it. I think, we've seen that with other vaccines. Some are lifetime immunity, some we have to get in boosters, but however that works, the fact that we have this opportunity, I think, changes the course of this pandemic.
Sarah, what are your thoughts?
Yeah, I agree with Suzanne. I'm definitely very hopeful for the future, and we knew this was coming, right? We saw the companies that were developing the vaccines, got the most up-to-date information, what was coming down the pipe. So we knew the vaccines were coming. So yeah, there was hesitancy everywhere, I think. But as nurses, we are scientists, and we have to look at the science. We have to trust the data, and yeah, there's a lot of trust. But I can say I couldn't have been more proud, when I came down and they were doing it down in the atrium of the hospital, very centralized area, and just to see all the staff were lined up, they're ready, and they're getting vaccinated, definitely gave me hope that we were turning a corner with the pandemic.
I think hope's a good word. Very nice.
So our final slide in this presentation is kind of a marker of where we are today in the pandemic. The United States has seen over 32 million cases with over 500,000 deaths. In Massachusetts alone, we've seen almost 650,000 cases and greater than 17,000 deaths. But on the hopeful side, in Massachusetts, there are at least 2.7 million fully vaccinated citizens, and that's as of last week. Just this week, Massachusetts' reopening plan is entering the phase called the new normal. And at Tufts Medical Center and Tufts Children's Hospital, we continue to care for COVID patients, but in smaller numbers. Vaccination is now open to all, and COVID tests are easy to obtain. It's as simple as purchasing a take-home test from a drugstore. So even though this seems like it's been going on for a long time, it's really amazing in a short period of time what people have accomplished in sort of where we're at in this whole managing this pandemic.
And then just a quick question for the panel. I'll start with Emma. How do you feel about the reopening and the future?
I mean, it's exciting. We're looking for to get back to normal. It will be a new normal, but it's exciting to be able to get out and see people, see family that you might not have seen for over a year. So I'm just excited to see what the future holds.
Yeah. How about you, Lulu?
I would say the same thing. I am also very hopeful that things will go back to normal, whatever that will mean now. But yeah, I am excited.
Tony?
I agree. I'm excited as well. A little bit fearful, just hoping that, we still keep our guard up and we still practice, safe standards, wear our masks and social distancing. And but it's so exciting to be able to vaccinate and vaccinate our patients now. It's wonderful. Yeah.
There's a question in the chat about initiatives that are being offered to the nurses by the administration to help them heal emotionally, both currently and long term. And I'll take that one. I have to say that the health and wellness of all the nurses and all the support staff and everybody at the medical center is at the top of our minds. We, on a daily basis, worked on this, and we formed a committee with frontline nurses as well as administrators to what can we do better. And Lulu said it great, that we really relied heavily on our chaplains. We have the most amazing chaplain department here that really is forward thinking and always coming up with new ideas to innovate, not to only support the patients as well as the staff. A couple of other initiatives, and I will be remiss because I'm not going to name them all. There are way too many to mention. But I would like to say that we do have a new member of our team here at Tufts, and his name is Bob. And if you don't know who Bob is, I suggest you follow him on Instagram. He's Bob the dog from Tufts Medical Center, and he has been a life changer here at Tufts, from visiting patients who are sick to visiting staff to having wellness visits to playtime with Bob. It's amazing what happens when you have this beautiful dog come up to you, wagging his tail. Your mood changes instantly like that, and that has just been a godsend. We have care carts that were led by nursing here that went around to all the different units that offered food. I mean, let's not forget food. Nurses like to eat and be fed during their shift, and we had a plenty of it. Carts that went around from our volunteer services to anybody who was coming out of the woodwork to help that was going up to units. We flipped a couple of areas to wellness and Reiki. where we offered Reiki, we offered laughing yoga, we offered aromatherapy, a quiet place just to go and to get away from it all. The floor that Emma works on worked on creating this code lavender, which is a wonderful initiative that if an event happens with the patient, a code lavender is called, and there's a team that swoops in and makes sure that they're to support the patient. I mean, the nurse, they get a little bit of a gift package, and they're encouraged to leave the unit, even if only for a few minutes, to go to this area, collect your thoughts, try to be well again. A lot of these things were done with all the support staff in mind, as well as the nurses, to make sure that they were kept well. So I'm sure there's a much more we can be doing, and we're never stopping, we're keeping going, but it is definitely on the forefront of our mind all the time. One question that's coming through the chat, which is for Tony. It says here that, did cancer patients stop care because they were afraid to come to the hospital? And how did you reassure them? I think this was at top of your mind all the time, correct?
Sure, absolutely. So we definitely did not stop cancer care. All of our patients continued to come in and receive their infusions and whatever treatment that they needed. And we needed to be really safe by doing that. So we did multiple things. We set up a COVID task force. We discussed things. I'm sorry, I think I was talking about that and then I got disconnected. But we did do that. And then we set up a screening process for our patients where we would screen patients ahead of time. And then our actual unit, we really got creative to have patients divided in the unit. So we had one half of the unit that was for healthy people that were coming in to get their treatment, to get assessed. And the other half of the unit basically was for sick patients. So we called it the Symptom Management Clinic. And the reason that we created that was twofold. One was to make sure that we were decompressing our emergency room department, because at that time things were so heated and resources were limited. So by triaging our own patients, I think we were able to assess, first of all, was those symptoms related to their underlying cancer diagnosis, or was this a potential COVID infection? So we had one nurse who actually went into the room. She went in with full PPE. She did everything that was imaginable for the patient. So accessing ports, starting IVs, COVID testing, you know, just assessing the patient and coming up with a plan for the patient. So basically every single patient, I'm happy to say, there really was minimal disruptions in their care. For those patients that we could safely convert to a phone visit, we did do that, or telehealth visits. So we set up labs in the local community, and we asked patients to get their labs checked a couple of days ahead of time, just to make sure that we had those results in time for the visit. So that's kind of how we organize things. And when we also had extra staff, I think the one nice thing that we could do is we could send them to, say, Emma or Lulu as support staff, just to kind of help out with proning patients or passing things in, whatever we could do from our point of view.
Tony, bring up an excellent point. The nursing community that was not caring directly for the front lines because of the roles that they were in, all pitched in. And I know Sarah mentioned this as well, that went to the units and did whatever they could. There was no question, what do you need me to do? I'm here. And that was a tremendous help to the ICUs and the floors that were overrun with patients, et cetera. There's a question in the chat, and this one will go to Sarah. How are you preparing for the new COVID-19 variants as they come along and the pandemics of the future? You did speak a little bit to this, but we didn't talk about variants.
Well, we're definitely keeping a close eye on the variants. I know the CDC has been very interested in all the different variants. And fortunately, you know, the vaccine manufacturers are doing research on all the variants as they come through. It's a normal process of virus. They do mutate, we do get variants. We know that year to year with flu, you know, the flu changes every year. That's one of the reasons we have to get different shots every year. They try to guess which variants will be predominantly, you know, in the United States, and they base it on that. So we know this is just a normal part of having a new virus, is there's going to be variants. So we're continuing to look at those and keeping a close eye on them. I know there's been some talk, proposal, nothing for sure yet about potentially having boosters on some of the vaccines. So, more to come on that. But and with any of it, I would make sure that, you're looking at reputable sources when you see the information. The aunt on Facebook that's posting things, maybe not the most reputable source, but, like I said, look to the science and look to the data anytime you're hearing things out in the public and the media about it.
Nice.
Yeah, I would just like to add too, the good news about variants is that they respond to the non-pharmaceutical interventions, and that is your masking, distancing, and washing your hands. All the things that we've done to kind of minimize the pandemic would still work for variants. So we kind of know all the behaviors that help us keep us safe.
All right, well, that just about wraps up our presentation. I would love to thank our panelists who I enjoy working with every day, and thank you for doing what you do. I think you're all amazing. And thank the Globe for allowing us to do this. I think it's important that we tell the story and the word gets out, because I think we hear a lot about sadness, etc., but there's a tremendous amount of positive things that are happening every day. So thank you very much. Everybody out there, stay safe, and we hope you enjoy the rest of your day. Thank you so much.
Thank you.